Welcome back. This is part 3 of lecture on preterm labor. We were discussing about fetal fibronectin, and so what are the indications? The indication is women should be between 22 to 34 weeks of gestation, and in threatened preterm labor, not in established preterm labor. Okay, so what are the contraindications? First is established preterm labor, which means the cervix has started to dilate. Secondly, the woman should not have any vaginal leaking, which means she should not have had Preterm. There should not be vaginal bleeding, and there should not be semen deposits. Okay, that means no history of recent sexual activity within the at least 24 hours. Okay, so these are the contraindications. Unfortunately, most hospitals they do not have this fetal fibronectin test performed because it needs actually a device. So how it is performed? Is it a blood test? No, it is not a blood test. Okay, it is the detection of this fibronectin, which acts as a glue between the chorion and the decidua, okay, between the endometrium and the fetal membrane. So, when we are performing a speculum examination, it looks like a high vaginal swab stick, but it is different, okay. So it's actually a swab. Just take this swab, and this goes into this specific tube, okay, not a random one. So there is some fluid in there, dip it there, and take some soot and drop some drops, 1 2 drops on this disc. This disc then it is inserted into this machine, and then this machine, it takes a few minutes, I think 5 to 10 minutes, and then it generates a report. Okay, if this fetal fibronectin test is positive, we definitely have to admit the patient, because that means in the next, depending on how high is, because the test may be quantitative, right? Quantitative means that it gives a value. So if the levels are very high, then the higher it is, the more risk she is of going into labor. Now, if it is negative, it has a very good negative predictive value. Negative predictive value means that if the test is negative, there are minimal chances that she will go into preterm labor, so you can safely send her home. That means, even God forbid, if something happens bad, you have a document, right? You can say, I did perform fetal fibronectin test and that was negative, so you are safe. Okay. So, anyways, when she is admitted, we have to perform certain things, right? Because we have to write a plan. How frequently should her vital signs be done? What medication should she be given? Does she need antenatal corticosteroids? Do we need to tocolyze her? Do we need magnesium sulfate for her? Do we need to? So all of this we have to, and how frequently her baby's heartbeat should be monitored. So all of this we have to, and how frequently her baby's heartbeat should be monitored. So whenever we are admitting a patient, we have to write all of this plain. So whenever we are admitting a patient, we have to write all of. If it is negative, of course, rule out what is causing this problem, right? If it can be a urinary tract infection, sometimes it can be something serious, like maybe it's appendicitis. It can be a uterus. So just know what is causing the pain, and then so a primary gravida presents with low abdominal pain. Say she's 28 weeks pregnant. So a primary gravida, there is suprapubic tenderness on speculum, and cervical os is closed, and no pooling of liquor is seen. And say there is no blood. And cervical os is closed, and no pooling of liquor is. What should be the next step? So we will have to do a fetal fibronectin test. Okay. What should be so, if fetal fibronectin test is performed for this patient, which is positive, how should she be managed? Yes. So, yes, we will admit her. Okay. So, positive fetal fibronectin, admit her. But remember that if there is blood in vagina, semen, or if there is leaking P-prom, it will be so. That's why there are contraindications for fetal. Now, if there is a patient, the same one actually, but with a different situation, a primary gravida who is 28 weeks pregnant presents with low abdominal pain. Now, if there is suprapubic tenderness on speculum examination, cervical os is closed, and there is no pooling of liquor or there is no bleeding, fetal fibronectin is performed, which is negative. How should she be managed? Of course, you know that. Fetal fibronectin is performed, we rule out the cause of the. If everything is fine, you can safely send her home, and you can give her an analgesic or just treat the underlying cause of pain. If now, what is tocolysis? Tocolysis is the medication which relaxes uterus. It is the opposite of utero. Now, what is tonics? Uterotonics increased uterine contractions, right? Tocolysis relaxes it. Okay. When do we want the uterus to be relaxed? When we want to buy time. When do we want to buy time? Especially for preterm babies, because we steroids. Why do we give antenatal corticosteroids to preterm babies who are likely to be preterm? Steroids. Why do we give anti? Because it enhances their lung maturity, but it's a course. Like, it's not just one dose. There are different doses which are given many hours apart. We will talk about it later. So when will we tocolyze? Okay. So what are the contraindications? Contraindication is if there is infection inside the uterus, infection of the amnion and chorion, which is called chorioamnionitis. When the woman is already in advanced stages of labor, like she's in the active phase of first stage of labor, when there is abruption of placenta. Okay, APH here I mean placental abruption, when there is bleeding. So can I tocolyze a woman with placenta previa? The answer is yes, if there is no active bleeding. With the placenta previa, we should not tocolyze if the woman is actively bleeding. Okay, then fetal distress, if the CTG is already abnormal. Why? Right, because it will kill the baby. Then PPROM. Okay, then fetal distress, if the CTG is already abnormal. So if there is a leaking of liquor, then it's a contraindication, spatial, even if there is no fever or there are no signs of chorioamnionitis, because there is a condition which is called neonitis. Okay, so subclinical chorioamnionitis means in fact, it is breathing, but it is not many, but it will develop its signs and symptoms within coming hours. Okay, but it will develop. Now, why do we aim for tocolysis in which women? So, to delay delivery long enough for corticosteroids to improve neonatal. And second is for in utero transfer to a neonatal ICU. What do we mean? And so sometimes, see, for example, if you're working at a secondary healthcare center where the neonatal unit is not too advanced, because there are three levels of neonatal care: level 1, level 2, level 3. So sometimes, see, for example, if level 3 is they can take care of very small babies. Very so if you're working at a hospital where you do not have level 3 neonatal care, and the baby you are dealing with is, say, just 26 weeks, for example, then what will you do? So if you're working, you will give you, if there is no contraindication, you can start corticosteroids, and then you can start tocolysis, and then I know in UAE it's a small country, but see, in some countries they are big. I know in UAE, in the next level 3 neonatal care may be some 6 hours away, 10 hours away. Okay, so then tocolysis is performed. Now remember that when tocolysis is started, it is many doses over. It can happen even more than 24 hours. Okay, it is many doses. So maintenance dose needs to be given. Now exactly what medications are required? First is there are two options which are the best. Okay, they have similar effect. The only difference is their cost and how they are given, the mode. Okay, the only difference is their rest. There are some medications which have tocolytic effect, but they are usually not used as a tocolytic. Okay, the first option, these two, just remember, atosiban and nifedipine. And what are the other medications which are, so these are the next three. Okay, now atosiban is an oxytocin receptor antagonist. So these are the next three. It is the opposite of oxytocin. It is given as parenteral. It's not a tablet form. The problem is it's costly. Okay. The problem is it's cost. This another medicine which has similar efficacy to etesiban, which is good, right? Similarly effective, but it is cheaper. That's called nifedipine. But the side effect profile of nifedipine is more. It has more side effects. But the side effect profile of nifedipine, a lot of hospitals, even in developed countries, they use nifedipine. Okay, they used etosiban. I'm not sure these days. They used etosiban. Now calcium channel blocker. It has some side effects, like it reduces the blood pressure of the. As a result, there may be a fetal heart rate abnormality as a result, and also it is contraindicated in cardiac patients because it can cause pulmonary edema, and when a patient is taking it, it can cause flushing. Okay. Now, next one is magnesium. In obstetrics, magnesium sulfate has many roles. Mainly, we use it for preterm babies for fetal neuroprotection. In obstetrics, obstetrics, okay, because preterm babies, when they are born over coming years, when they are children, they have these problems related to development. Okay, so it protects neural development. Okay, so it protects neuroprotection. Now, usually we do not use magnesium sulfates. Okay, so now the next mimetics. In poor countries, we are still using them, but they have significant side effects. Mimetics. So it is always better to use nifedipine instead of a beta-sympathomimetic, especially pulmonary edema. Now there is one medication, and beta-sympathomimetics can also cause, especially salbutamol, it can cause glucose from hypoglycemia. Okay, so terbutaline is used. Terbutaline is different. Terbutaline is given as a subcutaneous injection. We still use terbutaline a lot in obstetrics, but not for tocolysis. I mean, not over, say, for example, 24 hours. Yes, one single dose. When do we use it? First is before a procedure which is called external cephalic version, that is used for breech babies. Okay, so when we are performing this external cephalic version, before performing that we have to give subcutaneous terbutaline. And secondly, say for example, if a patient is in labor, she's having a lot of contractions and the baby is having fetal heart rate abnormalities, then even if we decide that this patient needs to go to the theater for cesarean section, this patient should be given terbutaline if there is no other contraindication. What it does is it relaxes the uterus for the time being so that baby can have adequate oxygenation. Okay, so it's just one single dose for these two indications. Okay, when I say tocolysis for preterm labor, it does not mean one single dose, it means over many hours. Okay, and what do we use? Atosiban and nifedipine. Now the next one is indomethacin, which is an NSAID. It is usually not used. It has tocolytic effect, but it is not used actually. And indomethacin is used usually for polyhydramnios. Okay, so but like it's restricted. I mean, there are only few indications. Okay, so only for polyhydramnios and during a specific gestational age. So, because it can cause premature closure of ductus arteriosus of the baby and the increased risk of necrotizing enterocolitis or NEC, okay, and neonatal renal dysfunction. So, the next part I will discuss in the the next video.